Hello. Thank you very much for joining us today for our conversation about radiation oncology care during COVID-19. I'm Shelley Fuld, Nasso, CEO of the National Coalition for Cancer Survivorship. This is our third webinar in our series about COVID-19. We've also launched a podcast, Cancer Convos, in which we talk with healthcare experts and patient advocates. We're delighted to co-host today's program with ASTRO, the American Society for Radiation Oncology. As we all know, cancer does not stop during this pandemic, and cancer patients currently in treatment face the challenge of a devastating diagnosis and navigating cancer treatment with a healthcare system that is stressed. We are honored today to have two experts in the field of radiation oncology and ASTRO leaders to talk about how the field of radiation oncology is working to ensure patients can continue to safely receive care during the pandemic. Dr. Ron Ennis is a radiation oncologist at the Cancer Institute of New Jersey. He has expertise in prostate cancer, genitourinary, and gynecologic malignancies. Dr. Lewis Potters is chairman of the Department of Radiation Medicine at Northwell Health and professor at the Zucker School of Medicine at Hofstra Northwell. Dr. Ennis will talk about how the field of radiation oncology has addressed safety for both patients and healthcare staff. And he will also highlight or preview findings from ASTRO's survey of radiation oncology practice, as well as ASTRO's advocacy on Capitol Hill. And Dr. Potters will share his frontline experience in the clinic in the epicenter of this pandemic. Thank you both for joining us. And now I'm happy to turn it over to Dr. Ennis to make some opening comments.
Hi, thank you, Shelley, and welcome everyone. Thanks to everyone who's joining on the call. We're honored and thrilled to be able to talk to you a little bit about what's going on in the radiation oncology community and cancer at large in the COVID pandemic era. Just for background, I'm sure people will be interested to kind of know what's been going on behind the scenes. And as soon as the pandemic hit Seattle, the radiation oncology community organically came together to start advising and talking to each other about how best to deal with the situation, with the primary goals of maintaining cancer care, but also ensuring safety for patients, staff, and also in hospitals very hard hit, maintaining hospital resources for all available diseases. It really has been quite a remarkable coming together. It started with the University of Washington in Seattle, putting out a webinar that was shared on the ASTRO community website about the basics of the COVID infection and personal protective equipment, which was all completely foreign to us across the whole entire country and to the radiation oncology community. And after that, many other centers started coming together with advice about what to do. Lots of conversations going on this hub, the RO hub, which is the ASTRO community, as well as through a variety of emails, conversations, etc. It was really quite remarkable, very organic, very collaborative. And what came out was, a few basic principles. I would say one basic principle was if there's COVID in your environment, you need to protect your staff and your patients. And pretty much across the board, and is borne out by a survey ASTRO has done recently. This involves using screening questions to assure that a COVID positive patient does not come into the department unknown. And that's if there is a COVID patient who has to be treated, very special precautions are done in that situation. And also of staff, screening staff to make sure they also are not infected. Beyond the screening, then routine use of a level of PPE has become a standard nearly throughout the country. I would imagine in some parts of the country where there's very little COVID at this point, that might not be necessary, but by and large across the country, masking with surgical masks, washing hands carefully at a minimum, and perhaps more PPE is being used as a standard for both staff and patients. And it is my impression that our centers, and Dr. Potters can address this later, but I think this is his impression as well, that has been very successful at maintaining a COVID-free, a safe environment for patients and staff. So that was goal number one. Goal number two was to continue patient care to the degree that it was possible, while not risking patient health at the same time. And there happened to be a modest number of conditions where the urgency to receive radiotherapy is lacking, and a delay of a month or two quite reasonable. The most classic example of that is a prostate cancer patient who is on hormone therapy. That is a very common combination of treatments, and the hormone therapy puts the prostate cancer at rest and prepares it for radiation treatment. But the amount of time to be on hormone therapy before radiation is a bit arbitrary, and there's a lot of room to extend that period of time without any risk at all. So that's a very good example where there was nothing to be gained by rushing a patient into treatment, even if that had been anticipated to start soon, and risk possible contamination, also using hospital resources, etc. So by and large, that type of patient has been delayed in many centers for a period of time. And there are some other conditions that, well, very favorable breast cancers, for example, may also fall into that situation. But for a significant, probably majority of patients, care really needed to continue or to start, because as Shelley, you alluded to before, cancer doesn't wait. However, even in that situation, there are sometimes a variety of ways that treatment can be given in terms of number of treatments, which require number of visits to the department. And in an effort to decrease exposure of the patients to the possibility of infection when they had needed to come into the hospital, despite the fact that we have created, we think, a COVID-free environment, many have adopted treatment courses that are also well established, but may not have been used routinely in a particular department, but for this period of time have adopted these shorter courses as a smarter way to take care of the patient. So these have been the main efforts that have gone on, and you know, ASTRO serves a tremendous role as a resource in posting a variety of information for users, and it's really been a remarkable coming together of our entire staff. Really quite proud of how we have responded to this. The other thing I think that's important for people to know about radiation is there's commonly a concern that cancer treatments and radiation specifically can suppress the immune system and make someone more susceptible to COVID, or make someone not do as well with a COVID infection at the same time as getting treatment. And that actually, by and large, is not accurate. Radiation by itself these days is given generally to very small volumes of tissue, and the immune system is very minimally affected to not affected at all. So anyone who has that concern obviously needs to speak to their particular physician about their case. But writ large, radiotherapy, as done for most cancers, will not impact your immune system. The one exception to that of significance is when radiation is combined together with chemotherapy, which is common. A significant minority of patients are treated that way with curative intent. And those situations, both the chemo and the radiation, can contribute to some weakening of the immune system. And in that situation, obviously, a conversation needs to happen about whether it's still appropriate and best to proceed, or best to hold off for a period of time to allow the COVID pandemic to get under better control. But it is important not to assume that cancer treatment will be dangerous for you. There are studies coming out suggesting that for many situations, cancer treatment does not impact on how someone does should they have COVID, nor make them more predisposed to get it. But there are certainly some situations where it is an issue, and obviously, in the end, it's a conversation between the patient and his healthcare team.
Great. So do you want to turn it over to Dr. Potters now to make some opening comments?
Sure, yeah, I think that'd be great.
Okay, great, wonderful. Thank you, Dr. Potters. Thank you, Dr. Ennis.
Great. Can you hear me, I guess?
Yes.
So welcome, and thank you for having us, and having us participate in this webinar. I think we have a good story to tell, and although I think nationally we're not out of the woods yet, obviously, I think it's really important for cancer patients to understand that during the crisis that their cancer does need to continue to be managed to some degree, or else we're going to wind up with what I'm sort of referring to is the third wave. We'll have the second wave of COVID, but then we're going to have a third wave of cancer. And so I think it's important for us as oncologists to do the best that we can to serve the needs of our patients. So I'll tell you a little bit about the story over here. I'm on Long Island, and we like to sort of call ourselves the epi of the epicenter at Northwell Health. Northwell Health is the largest healthcare provider in the state of New York. with 19 hospitals. And as part of the Northwell Health Cancer Institute, and within the Department of Radiation Medicine, we have 9 facilities spread out from Westchester, Staten Island, Long Island, New York City, where we treat patients on a daily basis. To put in perspective, the volume of COVID that we've seen at Northwell surpasses that of probably 80% of countries around the world. We've had 40,000 positive COVID patients through the health system, of which about 13,000 require admission. And of those requiring admission, about 20% wound up in an ICU. We've had the additional patients treated in the emergency room, about 9,000, and released, and then somewhere around 17,500 diagnosed through ambulatory centers. So it's a huge number. We expanded our inpatient bed service by almost 2,000 beds, just short of 2,000 beds, and pretty much filled that until the last 2 or 3 weeks, where the numbers of inpatients have gone down. And I think the discharges of, we've discharged almost 9,000 patients from our hospitals, and unfortunately, we've experienced about 2,500 deaths. So it's in that context of the environment that we've been working in through the Emergency Command Center that we've initiated a whole series of actions very early. You know, up until I think this week, I was half hoping that the asymmetry of this event in the New York metropolitan area would be, you know, just that, asymmetric. But I also think that based on some of the data coming out in the last several days, that we're still going to see this sort of wave through the country. So we decided, without knowing really what to expect and how this was going to impact radiation medicine and cancer delivery in general, we were very proactive initially in establishing and developing something similar to what Ron was saying, but a priority type system where we assessed and analyzed the patients in the queue. We had, at any given time, about 250 patients in the queue, sort of between the time of consultation and then the initiation of treatment. The intent was to follow the guidelines also that Ron mentioned, that are number one, the priority of the safety of the staff, and then secondly, the safety of our patients, and then third, to try and maintain access for our patients, and then fourth, to provide access to COVID positive patients if we're capable of satisfying the other 3 goals that I mentioned. And the good news and the cut to the chase is that we were able to meet all 4 of those goals. So we created a clinical criteria for our patients, and as Ron alluded to, a hormone patient with prostate cancer on hormones, a low-risk breast cancer patient, and a series of other types of patients were prioritized lower than those needing palliative services or more advanced, locally advanced types of cancers. And so as a faculty, we met and we reset the patient lists, and we were capable of putting almost about 48% of our patients into a lower priority. That allowed us to actually decrease, as the ferocity of the COVID crisis was hitting the health system, the number of new starts of patients. And that brought us down to a volume during the day of treatments at about 80% of normal. And again, you know, radiation patients are 5 days a week. They're coming for their care. You can't really just stop the treatment. And so the initial concern really was acutely whether or not we would be losing staff. And the good news was, at least within our health system, that the access to PPE was plentiful, and we were very aggressive in masking staff as well as patients early on. We had a number of staff who tested positive, who went home sick, but they were a small minority relative to everybody else. And to be honest, the engagement and enthusiasm and of the staff has just been tremendous throughout. The bravery that the techs have, where they're dealing with the patients on a day in and day out basis, is just really tremendous. And hats off to them. So we were able to get our volume down, and it took a couple of weeks to do that. But by the time that we got the volume down, we appreciated the fact that we weren't losing staff, we weren't having access problems for our patients. The patients were coming in. We had a screening process in place, and we've been able to treat our patients throughout. And except for cases that need operating room, like brachytherapy cases, whether it's prostate or GYN, but everybody else has been treated, and I think that this is a really positive aspect. I think when you look at the three legs of cancer care: surgery, radiation, and chemotherapy, medical oncology, I think in a lot of ways radiation has turned out to be the most resilient. We're not reliant on the operating rooms, which in a sort of binary manner just closed overnight, and limited the surgical oncologic approach for a lot of patients. And radiation, as Ron alluded to, is a local treatment without the immunosuppression that is typical with chemotherapy. And so our patients are tolerating care really without atypical side effects or risk that they otherwise wouldn't have. That's not to say that we aren't monitoring and assessing our patients carefully. One of the things that we recognized was that we certainly don't want our patients during treatment to need to go to the hospital, whether it's an emergency room for evaluation or the need to be hospitalized because of treatment-related morbidity or complications. And so we put into place a very aggressive weekly management program for our patients at high risk, the head and necks, some of the pelvic floor patients, some of the lung patients. And that's really worked very well in terms of maintaining fluid status, hydration, nutrition, and managing of side effects. We also stood up telehealth, as I think healthcare all over the world has done, and in particular the U.S., and that's decreased foot traffic in the office. And we also came up with an extra sanitizing process between patients on the linear accelerators, and so that actually adds a little time between patients. And so the scheduling of the patients coupled with telehealth has really diminished the foot traffic through the office. That's made our waiting room safe for the patients waiting treatment. So I think the initial concern of the radiation oncology community up front was, what can we do to accelerate treatment? And hats off to the efforts of our community and ASTRO for thinking ahead. But I think the positive story in this is that as we've gone through this, and we've been in a very busy, intense COVID positive environment, is that at the end of the day, we really do not need to compromise the care of our patients, and that we can provide standard of care, albeit when there are options to treat shorter or longer, the option for treating shorter is advantageous, but we don't need to be making things up, so to speak, on the fly, which allows me and my faculty to address a standard of care that would otherwise be routine for our patients. So that's my introductory comments. I'm happy to take any questions.
Great, thank you very much. And so to our audience, you can submit questions through the question box on the webinar, and we also had some questions that were submitted in advance by some of the participants. We have a really nice mix of patients and advocates and also providers. So there are a few questions that are more technical from providers, and then also some questions from patients. But I have a few questions I want to ask first. One is, so when you're making the call to delay certain treatments, how do you help patients deal with any anxiety or stress they have about delaying treatment, even when it's medically acceptable and and advisable given the risks of having to come in for treatment?
Right. So I would say the way I try to approach it is putting it in the context of what's best for them, because that really is what the approach is, and helping them understand that we are in a little bit of an unusual time, but taking that into account and the seriousness of a COVID infection, weighing all the pros and cons, we try and make that decision together. And to be honest, I've had that conversation with several patients. Most, have followed my advice, but I have had one or two who, after hearing that, said, I'd really rather proceed with treatment. And I think that was reasonable. I don't think the risk is, at least in New Jersey, was so high that that was an unreasonable thing. So, like most medical decisions, it's a collaborative thing between the patient and the physician. And it also is helpful to reassure the patient you're going to keep in touch and you're not going to just, leave them. So I generally have a 1-month check-in with them, usually by telemedicine. And if they're a prostate patient, for example, the use of the blood test PSA can be very helpful to reassure everyone that everything is fine. For other situations, you may not have that luxury, but nevertheless, checking in, symptoms are okay, and giving the patients, some sense of how safe it is here and that we're really moving towards getting back to normal. I think all that has been helpful for people to deal with that. And I would say, I think we are in New Jersey starting, as now the rate's coming down, to start to think about really getting back to normal, closer to normal operations, and bringing in some of those people that have been delayed. Of course, this will be a dynamic process, and depending on how intense the infection rates are in different locations, there may be different times in different parts of the country where things need to be delayed versus not. And I think it'll be always a conversation of a shared decision making between the patient and the physician.
I got to keep hitting the button to unmute. Anyway, the couple of comments. The first is, as you can imagine, when this was all hitting, and keep in mind the New York metropolitan area was hit the hardest early on, and the general public's understanding and acceptance of what was happening was still sort of fresh, even in a pre-lockdown time phase in the middle of March. And so, in fact, there was a lot of stress and concern on the part of some of the patients that we asked to delay therapy. And so, as Ron pointed out, I think it really did require conversation with the treating physician and the patient to make them understand that the safety, and at that time not understanding and appreciating what the risks were, that the safety of the patients really, from a COVID perspective, took priority over their cancer, because we know that delaying a breast cancer patient with low risk cancer for 2 or 3 weeks, or prostate cancer for a month or so, is not going to be detrimental to their outcome. The good news, and although I alluded to the fact that we were able to reprioritize a good number of our patients, and in fact we brought our census down a bit, the intent of doing that was to really preserve the staff and to create the time during the day to have this added sanitation period between patients and whatnot. And I sort of call that our soft landing, so to speak, and got us into a nice plateau where over the next couple of weeks through the end of April and now into May, we still prioritize our patients by name, but the fact of the matter is that we're capable now of starting patients in a routine manner without any delays whatsoever. And so we've been able to get our census back up and satisfy the waiting list of patients out there. So it's the good news part of this is the resiliency of a strong safety program with PPE, putting in place to have as a backstop the prioritization. But fortunately, the reality is that we've been able to keep going for our patients.
That's great. And thank you both for sharing how you're working to protect patients from infection when they come in for treatment. But we know that, we hear from patients that they're still, even if they have that confidence that, when they're in the office, that they're going to be okay, that they're still, getting there is a challenge for them. And, whether they have to drive or take public transportation, is just going out. It can provoke a lot of anxiety. So what are you hearing from patients about their concerns that are not necessarily related to treatment, but that are related to getting there, or to the other aspects of, being in cancer treatment right now while we're dealing with this pandemic?
So I'll start and then Ron. So it's interesting. For the patients who we see and consult and bring them in and who are undergoing treatment, they're actually incredibly appreciative of the access that we've provided to them. In fact, I was in the waiting room earlier today and speaking with some patients who were sitting there and asking them how they're doing. And of course, there's visitation rules now in terms of coming in alone, and the volume in the waiting room is less, so there's less of a it has a little bit more of an intensity to it, but the patients themselves were really quite appreciative. I think in a more macro way, my concerns are the patients who are not getting biopsied, who are not doing screening. And although a subject separate from what we're talking about today, I think there's a bolus of patients that because of surgical delays and biopsy and screening delays, that is more worrisome to me in terms of cancer management down the line than the patients who've been biopsied and are sort of teed up for their next phase of treatment in terms of coming in. But patients clearly are concerned about the safety of going outside, and there is anxiety of that, and we're very understanding of it. The good news is that we started within the health system about a week ago doing serology testing of the staff, and the fact of the matter is that our IgG serology conversion rate is very, very low. Which means that we've been able to protect the staff from seroconverting, and I think that patients should appreciate that, in the sense that while we do have the PPE and the personal relationships of seeing facial expressions and whatnot are lost, that it actually is serving a positive purpose, and that in the department, it is a safe environment for them to be here.
So I would just add that the issues about getting out of the house and coming certainly are germane for a lot of patients. And it's an opportunity for me or for physicians to help educate, and I have come to the place of feeling that with proper PPE, we really have a significant impact on the likelihood of getting an infection. We hear, like Lou has experienced, minimal staff, really no staff infections in the main campus in New Brunswick, and minimal in some of our other centers. And once we put in proper PPE in all the centers, it really seems to work. So I really try to reassure patients, you're going to wear a mask. You should, when you get one before you leave the house, wash your hands. And if you're wearing a mask, you're washing your hands, and you're not getting exposed to someone who is known to be ill, you really are very, very safe. And I think, educating people in that way has been very helpful for many, the reassurance of that. And again, everything is about weighing risk and benefit. And I agree with Lou, the vast majority of the cancer patients are thrilled that we're able and willing to treat them and are, not hesitant. But for those who are hesitant, I think some of that education helps. The one group that I do have, a little bit, I think we all would have a little bit more concern, but I do think these rules still are in place. But those who need use public transportation, particularly if it's a crowded public transportation, that's a much less controlled environment. I do still think using the mask and washing your hands and being careful where you touch will protect you to a very high degree. But certainly that is a little bit of a higher situation. In New Jersey, the vast majority of people are driving cars, so it's a little less of a problem for our particular patient population. But of course, that'll vary across the country.
Great, thank you. I've got a few questions from the audience. I'm going to kind of combine a few questions. They're asking about what kind of PPE do your staff and patients have or use? What is the cleaning process in between patients? And how much time do you have do you leave in between patients for that? And then also testing of patients for COVID during their treatment. That's a bunch of questions all rolled into one, I guess. So if you can address those, that would be great.
So real quick, we've established a screening station outside of the waiting rooms of our offices so that the patients are asked about symptoms and temperature check before they arrive into the reception area, the waiting rooms. And they are provided with masks and gloves daily at that station. And we just use regular masks. It's an interesting discussion to have in terms of the different masks, the N95 mask versus a typical surgical mask. A lot of the staff are comfortable wearing an N95 mask. Although the CDC has not necessarily recommended that they have to. Our health system is able to provide patient-facing staff N95s, and so a lot of our techs are using the N95s, but our back office staff and non-patient facing staff are using a traditional surgical mask. I've just been wearing a surgical mask throughout, and I got my testing yesterday. I'm negative, so I don't know if that's good or bad, but the fact is that it is negative. In terms of the cleaning between the rooms, I think that's a great question. So obviously the linear accelerator, the treatment rooms where the patients are usually degowned and lying on the table, what we've established is a 5-minute settling period where once the patient leaves the room, that we allow the air of the room to sort of settle for 5 minutes with nobody in the room. And then we go in and we use sterile wipes on the table and horizontal surfaces. And then they require a 3-minute drying period, and then we bring in the next patient. We have treated COVID positive patients, and we have a policy for doing that. We treat COVID positive patients at the end of the day as the last appointment. And then there's a 1-hour settling period where the room is left for the air to sort of not circulate before you go in and clean and allow that sterile cleaning to dry. And so it works better, obviously, at the end of the day in terms of the delay. So it's I think it's a real debate, and I've seen a number of blog postings from different centers around the country, and it's not completely clear what the value of testing patients before coming in is. I was just at a chairs meeting yesterday within the health system, and even the the various, and at Northwell, we have 4 or 5 different PCR testing modalities in terms of brands or solvents and how they're done. And they each have issues associated with false negatives and positives, so that it's not completely clear that other than just assessing the patient's symptoms, that you're going to really find issues with COVID that then may lead to the suspicion where a true positive test is going to be more meaningful rather than just checking everybody.
So yeah, so just a few comments, very similar experience to what Dr. Vadas has just shared. But so the PPE and its availability certainly has been an issue in some centers. We were barely able to kind of keep up with our needs early on in the epidemic, and then our health center has been able to acquire PPE, but that's not always the experience, and it is something that we're advocating through the federal government, as most of the healthcare community, to make sure there's enough PPE. We are not caring directly for very many COVID patients, so our need is a little less acute, obviously, than the inpatient units and ICUs, but nevertheless, across the country, an ASTRO survey has indicated that it is an issue for a minority, but a significant minority of our community. So this is something that we need to all advocate a little bit more for, to get adequate PPE. What's adequate PPE? As Lou alluded to, there's some uncertainty about it. I would say in a community where the infection is prevalent, which is a high proportion of the country by now, a surgical mask, I think, is essential for both patients and staff. Gloves and/or careful hand washing is also essential. The higher levels of protection are a little bit more ambiguous unless you're dealing with someone who's infected. We here have gone to a higher level in the New Brunswick campus of Rutgers, Robert Wood Johnson, so that all staff are wearing eye protection and N95 masks for all patients. Patients are wearing regular surgical masks. The vast majority of the other healthcare team, so nurses, myself, I just wear a regular surgical mask. But the therapists are in very intimate contact with the patients for a longer period of time. Some of the types of treatment really do put them at risk. For example, cancer of the lung or cancer of the head and neck, where the patients often are coughing, and the head and neck patients really cannot protect their mouth, but cannot really wear a mask just because how the treatments are done. So for those, really, you do need that higher level of protection. And we just decided to just apply it across the board to all patients. A COVID positive patient, an actively infected patient, we use, even get full gowns, the entire staff. We have some staff contacting the patient, other staff only dealing with the treatment consult to run the treatment in a way that we don't necessarily do otherwise. And the post-treatment cleaning is as Lou described. We treat at the end of the day. You have to leave an hour to allow air. Unless you have a negative pressure room, you've got to allow an hour for air circulation before anyone even goes in. And it's done what we call a terminal cleaning, which is a more intense sterilization than after a typical patient. So those are the precautions that we've put into place in terms of the PPE and in terms of dealing with how to clean the rooms and protect staff and patients. And I say it is working quite well. Lou alluded to the testing of patients, and just to share kind of what we are doing. And it's, as Lou said, it's not clear, and there are risks with knowing and not knowing, so to speak. We have decided to test certain populations just to have that information, being aware, of course, that a test doesn't guarantee negativity. But we are testing patients who are about to start chemoradiation, because those patients will have some suppression of the immune system, and we would want to know if they're infected or not, and might not actually start treatment. If they're infected, that would be a judgment call between the radiation oncologist and the medical oncologist. We are testing the head and neck patients for the reason I alluded to before. They really cannot wear a mask during radiation treatment, at least the way we do the treatment. We don't feel that we can do that, and therefore they have a potential to cough and expose staff more. And therefore, we want to know if they're infected or not. And again, if they are, we might delay treatment until it clears or might not, depending on the acuity of the medical condition. We're also testing all patients coming from nursing homes or rehabilitation facilities. And there it's more about, they're just, as we know, unfortunately, much higher likelihood to have the infection. And we kind of want to know for that purpose. And again, we may elect to delay treatment, hold treatment if indeed they are infected. So that's what we're doing as of about a week and a half ago. It's an ongoing dynamic kind of thing. We're going to learn. We may move at some point to testing everyone. We may decide it's really not that valuable. You just have to treat everyone with universal precautions and assume everyone might be infected, and you don't need to know unless they're symptomatic. I think this is something we're all kind of discussing as a community right now. But that's what we're doing at our center.
Great. Thank you both. That's really helpful. So can you talk a little bit more about palliative radiation? We had read some reports that palliative radiation was being delayed or reduced. And I know when we talked earlier this week to prepare for this, you guys had some thoughts on that. I wonder if you could share how that's being delivered and what you're doing in that regard.
So in New Brunswick, and I think most of the country outside of perhaps in really the intense New York experience, I do not think there's any delay or non-delivery of palliative treatment. That's the most acute and the most urgent. The only thing that might vary is that there are different ways in terms of what we alluded to before, number of treatments that can be done. And some regimens will deliver fewer treatments and some longer. And there are pros and cons to that. And in a non-COVID environment, you might feel, well, risk benefit, I'll give them 10 treatments. But in the context of all the risks that we talked about before, you might decide to do it in 1, for example, or 5. So you may shorten the overall treatment course, but I do not think there has been, certainly not in our whole 10 hospital system has there been, and nor do I think outside of New York was there a pressure to actually not be able to deliver palliative treatment. In New York, I'll let Lou speak to it more because he's really much more involved. There was a little bit more intensity to ratchet down the number of cases and a concern about that, and I think he's more in the know about some of that information.
Yeah, you need to unmute.
Can't hear you.
Unmuted. Good. Okay. Thank you.
Yes, we can hear you.
So a couple of things, because I'm a little bit passionate about palliative care in general, even in a non-COVID environment. The good news is we haven't had to compromise the offering of treatment for any palliative care patients, whether they're inpatient or outpatient. And that's whether they have a neurologic cord compression, airway compromise, or a bleeding episode, or severe pain management whatsoever throughout the entire crisis. And so all the patients have been treated appropriately for palliative services. And I think that that's important for others to recognize that level of compromise, fortunately, was not an issue. And no matter what happens in terms of how this waves through the country, we were just so inundated with COVID that the ability to continue to offer palliative services, I think, is also a real tribute during the heat of the battle. There was an article that was published out of Memorial Sloan Kettering that got some press, and to be honest, I thought it was a really great article that outlined alternatives for how patients can receive radiation for palliative purposes in a shorter manner than typical, and the idea was to prepare for the type of situation where access was going to be limited to patients where they wouldn't otherwise be able to be treated in a normal fractionation or a number of treatments type of schema. And to me, what was really positive about that article, although the press didn't necessarily pick it up that way, was that the recommendations that they made were based on evidence that already exists. And so that it wasn't the idea of coming up with new or improvised approaches for palliative radiation therapy. And so I think in a take-home way, it demonstrated in a more global manner and in a non-COVID environment, the fact is that there are options for us shortening radiation treatments for palliative patients. And these are things that in a normal situation, we may want to take into consideration. So I know that there was concern perhaps because of that article, but I saw that as a positive. And then lastly, and this happens all the time, is the risk benefit of offering palliative therapy based on a patient's performance status, end of life status, and advanced disease or whatnot, tends to tip in the, well, we have nothing to lose type of thing. And we've heard that before, right? And, the reality is that if anything, if this forces us to be a little bit more honest about the opportunities for helping patients and having the more difficult discussion about perhaps not treating patients, then I think that's a real positive that comes out of some of this COVID crisis.
Great, thank you. So you mentioned the decline in screening, and I wanted to see if you could talk a little bit more about, the reports are that it's pretty dramatic, that people are not going in for, regular screenings that they would have otherwise gone for. So can you talk about what that's going to mean for cancer diagnoses and treatment going forward?
So, I mean, it's a really serious concern. For example, I know in radiology departments are down, perhaps 80% of volume. You would imagine that means 80% fewer mammograms this month than last month. And then there's going to be a backlog and delay in getting appointments. I mean, there is a risk of people being diagnosed at more advanced stage and having an inferior prognosis. So, one of the messages I'm hoping that we can kind of convey is that, if the healthcare system that you can access has proper PPE in place and proper protocols in place, don't delay your cancer care. Have a conversation with your doctor about risks and benefits, but seriously consider moving forward, because these are, as we all know, cancer really doesn't stop for anything. The delay in surgeries, was necessary in many hospitals in the New York metropolitan area. We had to and treat these COVID patients, and there just was no OR access in many of the hospitals, but that is now thankfully being relieved. Hopefully across the country they won't experience that, and there will always be OR access so the cancer surgeries can go on. And if a facility is doing it safely, I would encourage patients not to be afraid. Make sure the proper precautions are in place, but don't delay your care. But go forward and speak to your physician about your concerns, but don't blow it out of proportion to the point that we suffer from cancer while protecting ourselves from COVID.
I just want to make a couple of comments. I'm pretty passionate about this because I'm really concerned about what I referred to earlier on as the third wave. And there's two cohorts of patients in this country that are really in trouble, and those are cardiovascular patients and cancer patients. And the good news, bad news about cardiovascular diseases, and something I've always been jealous of cardiologists with, is they get an answer relatively quickly in terms of mortality, and they can run studies really quickly, where cancer, it takes us years to understand the answers. And I think when you look at excess deaths in New York and suburban New York area, outside of COVID deaths, what you're seeing is a tremendous amount of patients who died of other causes. Most likely, a good number of them are cardiovascular deaths. So those are going to wash through the system relatively quickly. The patients that I'm more concerned about are the cancer patients, where a really interesting non-peer-reviewed study out of the UK of mathematics that I have to admit I don't completely understand, of epidemiologists, looked at the delay of surgery for cancer patients and identified that a 3-month delay is probably associated with, in general for cancer patients, is associated with about a 5% increase in overall mortality. And a 6-month delay would be equivalent to about an 11% increase in overall mortality. Whether those estimates are true or not, based on their math is to be determined. But I think it does demonstrate the risk to the cancer population. I mean, it was only, I think, in February that the cancer statistics came out for 2020 that showed, again, a year-over-year decrease in cancer mortality in the United States dating back to 1991. And it would be a shame to lose that momentum because of the delays associated with surgery, as well as delays associated with screening. And earlier this week, there was a publication that showed, in fact, that screening is down somewhere, as Ron alluded to, between 80 and 90% for colon, breast, and cervix. And that's going to create an issue to it, several issues, I think. It's going to create an issue where you're going to have access issues based on the bolus of patients needing to be screened in terms of being able to provide those services against what otherwise would have been a sort of a baseline of patients needing those services that usually push up against capacity in most facilities. And then because of the delay, patients are going to face the risk of stage migration, where because of the delay that they're going to present with potentially more advanced disease. So I think the story for cancer screening is because, it's hard for us to control operating rooms and getting patients into the operating rooms. But from a screening perspective, I think as soon as our radiology colleagues are capable of providing services, that I think it's an important message for us to get out to our patients, that they need to continue with their routine screenings for cancers, or if they're having symptoms that require a visit to a physician, that they should address those as in a pre-COVID sort of manner, and try not to put these things off. Again, everything is a risk benefit. Everything we do in life is a risk benefit. But I do think that there is going to be value to continuing and moving forward in screening, and in terms of patients presenting to their primary care doctors with symptoms that need to be addressed.
Great. So now I want to turn to, you mentioned telehealth before. We know that telehealth has really exploded in this pandemic, keeping people at home. What can cancer patients and survivors do to get the most out of a telehealth visit? And how do you foresee the use of telehealth in cancer care after the visit, after we get through this pandemic?
So, I mean, I would say for now, you can get the most out of it if you have the technology so that you can do audio and visual. So to the degree that you can, and if you don't have it yourself, if you can get a friend, a child, a colleague to help you get yourself set up, and if your physician is set up for both audio visual, that does really go a long way to making an effective conversation between the physician and the patient. And also, having your loved ones or close family members or friends along with you. Many of the platforms can actually, you don't have to physically be together. So if you're doing social distancing properly and you don't live together, that loved one could be brought into the conversation on a lot of these platforms, and that would also be a plus, like you might normally do by bringing those people with you to a telehealth visit. So I think those, and obviously preparing for the visit, making sure you have your medications listed, and all the things you might do otherwise will help make the telehealth visit as effective as possible. The phone alone is, less good. Sometimes it's still the right way to go. Minimizes the need to come into the hospital, possible exposures, etc. But I think less good. In the long run, I do think telehealth can play a very important role. What its parameters will be, I'm not quite sure, but as I say, I do feel like it's pretty effective communication when you are able to see the patient and he or she can see you as a physician, and you have like a relatively natural conversation. Obviously, the physical exam components are missing, and that really, the importance of that is almost always some level of importance. But again, risk-benefit trade-offs. In many situations, the need is much less, and sometimes really not at all. In many situations, it's absolutely crucial, and even in the COVID era, we here in New Brunswick are physically seeing, significant proportions of new patients for sure, because the physical exam is so crucial to that. So, and I think it will evolve, and I think different specialties will use it differently. Some specialties maybe use a video to do some of the physical exam, like a dermatologist, for example. There are all kinds of devices coming out that I've heard about, and I'm sure others have as well, that can be linked to software to have someone listen to your lungs virtually, to listen to your heart virtually, et cetera, so that, with these extra tools, I've heard of ENT tools also available to look inside the middle ear. So, with those tools, really quite a bit opens up to be possible, and I think it will be quite interesting. And assuming the financial, the regulatory, the legal, all those issues are dealt with. Some of it right now is being dealt with through blanket CMS rules that are allowing things to proceed in a way that aren't normally allowed. So that all needs to get sorted through. But I think patients and physicians like it for a lot of encounters, and it could make a significant impact on the quality and the convenience of medical care going forward.
Great. Muted again. Can't hear you.
You guys seem to be controlling this mute, so it's okay. But then, no, I know not you, not the three of us. Somebody behind the scenes. But I would just echo what Ron said about telehealth. It's it's interesting. It's one of those technologies that's sort of been ready to go, and obviously it was ready to go because it's the amount in which it's being used in healthcare just generally is just astronomical. Almost 80% of healthcare now is through telehealth. I do think there's a learning curve, obviously for patients in follow-up. My patients, I treat prostate cancer. It's important to follow up with the PSA, and if that's a good number, then the physical findings in the rectal exam is not as relevant. In a head and neck patient, in a GYN patient where examination is important, and that obviously is going to require a different level of visit for that particular patient. But I am bullish on telehealth, and I think that we're going to learn how to do it and use it better. The technology from the patient's perspective is going to get better in terms of accessing, and as Ron pointed out, there will be devices that'll help with some of the physical exams. But say seeing a patient first in telehealth, getting their history, and making a baseline determination, and then follow that up with a face-to-face visit where physical findings can be assessed. And which diseases is that important is all something that needs to be worked out. Personally, I'm comfortable with managing my patients and consulting with my patients at least initially this way, and it seems to be working.
Great. So I know we're a little bit over time, but I have to end on a positive note. So I want to ask you both and I like to ask this of all of our guests, do you see any silver linings through this that will be with us long term, whether it be, personally or in how we deliver cancer care?
So I'll start and leave the conclusion to Ryan. I'm pretty bullish. I mean, I'm concerned is, like I pointed out earlier about, the risk of delayed care and screenings, but, I also demonstrated and spoke to the fact that, our staff and radiation oncology is pretty resilient in terms of being able to provide a standard of care that patients and a quality of care that the patients, expect from us. And I think going forward that we're going to be able to continue to do that, without compromise. And if it forces us to start thinking about studying shorter courses of treatment so that patients are in and out, then let's go for it. And it's an area within radiation oncology we've been addressing anyway over the last number of years, the idea of hypo fractionation or shortening treatment course. And so if this forces us to continue along that path, then albeit. But I think the silver lining is that we're here for the patients. We are open and providing a routine standard of care. And it's important for them to, despite the anxieties, which are understandable and acceptable, that it's important for them to appreciate the needs for that care if they have diseases that require treatment.
So
Thank you.
I think there are always mixed. Every experience has got its good silver linings and its negative aspects, and even something as difficult as COVID, there are some silver linings in our space in particular. I think telehealth is kind of the longest lasting change, fundamental change for the positive that would not have accelerated. It's been around for a while, but for all kinds of reasons, really wasn't happening the way it was in a lot of society. And this is really just going to break that logjam. So I think that's the kind of most probably impactful thing long term. The heartwarming part, I think there's also a very strong heartwarming part. I think the way physicians, the healthcare community, and patients have kind of worked together to solve this problem and to adapt and be flexible and figure it out and do it in a really thoughtful, collaborative, positive way has just been phenomenal. And I must say the radiation oncology community in particular, just the way we came together so organically and so helpfully and so positively. I mean, it's just been, I'm very, very proud to be say I'm a radiation oncologist, the way we handle this. And not to say, obviously other specialties I think have done the same, but this is the one that we know best. And I'm really proud of how physicians, healthcare workers, and the entire radiation oncology team has been able to rise to the occasion, adapt to the situation, and keep the patient first. We really did that. We kept the patient in our focus as the primary thing throughout the entire episode, the entire conversation, and I'm really proud of that.
Wonderful. Thank you very much, both of you, for joining us and for your focus on patients and making sure that they can get the treatment they need. I also want to thank the entire team at ASTRO for collaborating with us to co-host today's program. We are grateful for your focus on patient needs and your partnership with patient advocacy groups. I also just have to give a shout out to the NCCS staff who are working hard to provide accurate, reliable information for cancer patients and survivors and to continue our programs and advocacy. For more information and resources on COVID-19, you can visit our website, canceradvocacy.org. You can also subscribe to our podcast, Cancer Convos, by going to canceradvocacy.org/podcast. We look forward to presenting future webinars and podcasts on COVID-19 topics and beyond. Thank you again for joining us. Thank you, Dr. Ennis and Dr. Potters. I hope everyone has a wonderful day and stay well.
Thank you.
Thanks for having us.